Hey everyone, it's Sarah with registerednursern.com, and in this video I'm going to be doing an NCLEX review over GERD. And this video is part of an NCLEX review series over the GI system, so be sure to check out those other videos. And as always, in the YouTube description below or at the end of this video, you can access the free review quiz that will test you on GERD. So let's get started. So what is GERD? GERD stands for Gastroesophageal Reflux disease. And based on this long name, we know that we're dealing with the stomach, which is gastro, and the esophagus, which is esophageal. And GERD is a chronic condition where stomach contents is flowing back into the esophagus. So in your stomach, you eat food, you have acid and enzymes, and it's just going back up through the esophagus. And the cells that line the esophagus are not made to withstand acidic conditions, so they start to become really irritated. Now, why does this happen? This usually happens due to a weak or damaged lower esophageal sphincter, which we'll refer to as LES. Now, GERD is sometimes referred to as acid reflux disease. So if you hear someone say, I have acid reflux disease, they mean this as well. And one thing you want to keep in mind is that some people have random episodes of acid reflux and then it goes away. Now, it's termed GERD when the acid reflux tends to occur twice a week or more on a regular basis. So it's a chronic condition that's been happening over time. And if a patient has this, they have GERD, acid reflux over a long period of time, they need to go to their physician who needs to look at that, maybe prescribe some medicines because this disease can cause some long-term complications. Now let's look at the normal physiology of swallowing food. What happens when we chew our food and swallow it in someone who doesn't have GERD? Because we know with GERD, whenever the patient is swallowing their food and it enters into the stomach, it is getting back into the esophagus due to a weak lower esophageal sphincter. So before we dive into the patho, let's see what our body should do normally. Okay, so we chew our food, digestion starts in the mouth, and we swallow it. Now that food is squeezed down through the esophagus, and the esophagus is made up of smooth muscles that help guide that food down to the stomach, and that's called peristalsis. Now, whenever that happens, your lower esophageal sphincter relaxes and it allows that food to go into the stomach. Now, after it relaxes, it closes, and it closes very tightly because it doesn't want any of that contents, the acid, the enzymes, the food, to go back up through that esophagus. So that is what will happen to someone who doesn't have GERD. Now, with someone who has GERD, what is happening is that we're having issues with the following things. We're having issues with our esophagus, our lower esophageal sphincter, our esophageal mucosal lining, and the stomach acid and the food contents. So let's take a look at what's going on with esophagus and GERD. Okay, we learned that the esophagus squeezes food in wave-like contractions and works with that lower esophageal sphincter, which relaxes to let food in. Well, sometimes what can happen with the esophagus is that it can have impaired motility, and it will cause the lower esophageal sphincter to close at irregular times, which can lead to GERD because that acid is back flowing up through that esophagus, and the LES is closing at irregular intervals, and it's allowing that acid to get into that esophagus and erode it and form ulcers. Now let's look at our LES, lower esophageal sphincter. Now it's right here. It's a collection of circular muscles at the end of your esophagus, and it opens and closes. And when it closes, it's supposed to be a really nice tight seal, so nothing can back up in there. Well, with GERD, we learned earlier that it can become weak. And why does it become weak? Well, if it has some increased pressure on it, it can damage it and make it weak over time, or medications or other chemicals can damage it and make it not close as tightly. So let's talk about some things that can cause increased pressure on the LES. Pregnancy. As that baby grows, it pushes up on this diaphragm, and the diaphragm is very close to your stomach and your esophagus. Puts pressure on there, which in turn will put pressure on the LES, cause it to not close properly, and you get acid reflux. Obesity, same principle. Overeating, eating too much food. If you eat a really huge meal, put all that food into your stomach, it will increase pressure upward onto the LES, cause it to leak the gastric fluid into your esophagus, and a hiatal hernia. Let's talk a little bit about hiatal hernia. What is it? Okay, what happens is that the stomach is supposed to be below the diaphragm. Now, with a hiatal hernia, the top part of the stomach has herniated through a weak part in the diaphragm. The diaphragm is the blue area. And it's just herniated up through there. And what can happen is that gastric acids and foods can just pull in there. And it's very close proximity to the lower esophageal sphincter, which is going to cause a lot of pressure on that and mess it up and won't close properly. So a hiatal hernia can cause it. Now, medications or some types of chemicals. Antihistamines can weaken your lower esophageal sphincter, calcium channel blockers, sedatives, smoking, and certain foods, which we'll really get into the diet teaching, but just to list some, like fat and greasy foods, peppermint, spearmint, any of those type things can weaken that LES, and that's why you tell the patients to avoid consuming them or limit the consumption of them. And another thing that can cause GERD is delayed gastric emptying. And what's happened is that the stomach isn't emptying its contents through the small intestine like it should. Instead, it's staying in there too long. That increases pressure on the LES and can weaken it. And some drugs that can do that are anticholinergics. So you really want to watch out for your patients who are taking those medications. Next, esophageal mucosa lining. What happens to that is that the cells that line your esophagus start to erode and they become inflamed because they're not made to be in contact with all those acids and enzymes. So the person can develop a condition called esophagitis, and due to that chronic inflammation irritating those cells, there is an increased risk of esophageal cancer. Also, some other things that can happen with esophagus are these other complications due to all that chronic inflammation. They can get strictures where you have narrowing of the esophagus just from all that chronic inflammation causing scar tissue to build up over time, and it will narrow it. Another thing is that they can develop what's called Barrett's esophagus, and this is a very interesting disease. And what happens is that the lining of the esophagus that was normally there starts to change, and it will actually match the cell lining that is found in the intestine. And because of that, the patient is at risk for a rare form of cancer. So it's very interesting that it can do that. Another thing, they can have bleeding as well. Next key player is the stomach acid, like the hydrochloric acid and pepsin and the food contents. And again, when they do, they just get up there in that esophagus and they erode those cells and that lining. And what can happen is that this acid not only can go past the lower esophageal sphincter, it can go up all the way past the upper esophageal sphincter. And what's past that is your pharynx, up through your ear canals, and then in front of that, a little bit in front of your pharynx, is your respiratory system. So that acid can really get in there and cause some problems. And whenever it does that, it's referred to as laryngopharyngeal reflux, and GERD can lead to this. So just think about it. If the acid goes up into the pharynx, what do we have up there? We have our throat, we have our ears. So we can get some ear infections. It can even go down into the windpipe where we can get some pneumonia, lung infections. Also can aggravate the patient's signs and symptoms if they have asthma. They can have coughing and even voice changes, like their voice sounds hoarse from where that acid is just going up where the voice box is, where everything's at, and just wearing that away and causes them to have this hoarse sounding voice. Now let's look at the signs and symptoms that you may hear your patient report to you who has possibly GERD. Okay, the most common thing that patients will report is heartburn, and this is like a burning sensation in the chest. It can even be so painful that the patient may confuse it as that they're having a heart attack. So they may need a cardiac workup as well, just to ensure that that isn't what it is, or it's GERD. Another thing they can complain of is epigastric pain, having stomach pain, regurgitation, and this is where the acid contents is going up in through the throat. They may report like a bitter taste in their mouth, or whenever they're laying down in a prone position, they can feel that food coming up as well. Another thing is dry cough, which tends to be worse at night when they're lying down sleeping, as that acid is coming up through that esophagus. They start to get choked on it and they cough, or they may have a cough throughout the day. Nausea, problems swallowing. A lot of patients I've had report just feels like there's a lump in my throat, and that could be, again, possibly from the erosion or regurgitation, the acid coming up. Another thing is that they may have recurrent lung infections and ear infections, and we learned about in the patho why that is. Now, not all patients will report heartburn. Some patients don't even have that typical indigestion type pain. They just may have that chronic coughing, the voice changes where their voice is hoarse, or ear infections. So may want to look further into that, see what it is. Now, how is GERD diagnosed? As the nurse, you need to be familiar with the names of these tests so you can be able to tell your patient what they're going to be doing, because a lot of times patients are like, hey, I'm going for this test, what is it? And you'll have to talk to them about it or just explain what to expect. Okay, one way to diagnose GERD is an endoscopy, where they take a scope, they look down through the esophagus, and they can assess the esophagus for any changes like narrowing, ulcers, erosions, things like that. Another test is esophageal manometry, and this is where they assess the function of the esophagus's ability to squeeze that food down into the stomach and how that lower esophageal sphincter is closing. So that can assess that. Another test is pH monitoring, and this is where they put in a small tube, and the patient will have it in there for about 24 hours, and they'll just go on about their activities of daily living. And the tube will measure the amount of acid that comes in contact with the esophagus, and that can help them see if they have GERD. Now, what are the treatments for GERD? We're really going to hit on this in the nursing interventions and diet, and we're going to go over the medications in depth, but let's see in a nutshell what the treatment is. Lifestyle changes, such as losing weight, because obesity can cause this, changing your diet, the foods that you eat, quit smoking, things like that. Medications, and in the most severe cases, they can have a surgery called fundoplication, and this is where the fundus of the stomach is placed around the lower part of the esophagus. So in a sense, it helps to strengthen the lower esophageal sphincter. Now let's talk about the nursing interventions. What are you going to do for a patient who has GERD or you suspect has GERD? Okay, one thing we're going to do is we're going to assess. We're going to assess the patient's frequency and quality of pain, because a lot of times patients may say, oh, my reflux is just acting up. And in reality, they may be having a myocardial infarction, a heart attack. So you want to be able to differentiate between those two. Another thing is you want to assess them for other signs and symptoms that's not the most obvious to GERD, like that heartburn and indigestion. You want to look at the respiratory system. Are they having chronic bouts of pneumonia, or is their asthma really flaring up, or are they aspirating a lot where the regurgitation's happening, that food's coming up and it's going into the lungs? And some signs and symptoms of aspiration or coughing, decreased oxygen saturation. If their sats were good, then all of a sudden they're down. Abnormal lung sounds and increased respiratory rate. I actually had a patient who did this. They were there going to be having surgery. They were really mobile. They could get up, do things for themselves, and they had just ate breakfast. About an hour after breakfast, they had laid down to take a nap, and they had aspirated their food where they were having regurgitation, and their SATs were like 97, 98% throughout the whole day, and then all of a sudden they were dropping down in the 80s. They were having chronic coughing. They were having voice changes where they were really hoarse, and their respiratory rate was really high. And we did a chest x-ray, and it showed that they had aspirated some of that breakfast from earlier, and they had severe GERD. So can happen. Another thing is that you need to watch out for those voice changes and a chronic cough that tends to get worse when they're lying down. Okay, another thing is their pain. Ask them, is it aggravated after you eat a heavy meal? And ask them the foods that make it worse, and help them develop a diet to substitute some other foods that they can incorporate instead of eating those foods that make their GERD worse. Then you want to look at their medication history. What meds are they taking? Because we learned that certain meds can cause the LES to relax, like antihistamines, calcium channel blockers, and do they smoke as well? That can affect that. And anticholinergics. They decrease gastric emptying. Then you want to educate them. So what you want to educate them about mainly is a lot of food stuff, because this is what's causing our problems, our food. So you want to educate them to eat small meals. Avoid really just filling up on these really large meals, because it's putting a lot of pressure in the stomach, and then in the end is going to put a lot of pressure on that lower esophageal sphincter. And they need to avoid foods that relax the lower esophageal sphincter, like greasy, fatty foods, alcohol, coffee, peppermint or spearmint. And watch soft drinks, because all that carbonation, once you ingest those, increases pressure in the stomach and increases pressure on the LES. Another thing is that they want to make their last meal about 3 hours before bedtime to decrease the chances of regurgitation, because when they eat a meal, they lay down on their back. That puts a lot of pressure on the lower esophageal sphincter, and it can cause some reflux. Then they want to sit up 1 hour after meals. If they're obese, they need weight loss, because that puts a lot of pressure on the sphincter. Smoking cessation, and watch acidic foods, especially if they have erosion in the esophagus. Foods like tomatoes or citrus fruits and juices can really irritate that esophagus even more. And then plus, if they're having regurgitation, where this contents is backflowing, it's just going to go from the stomach and back into the esophagus. So they need to watch those foods as well. Now let's look at the medications ordered for patients who have GERD. As the nurse, you want to be familiar with these drug categories and what they do. Okay, so first type that patients take are called antacids. And what antacids do is that they neutralize that acid, so it's not as acidic whenever it backflows into the esophagus and won't erode it as much. Some drugs that are antacid are like magnesium hydroxide or calcium carbonate, and you give these to the patient, they chew them, and then they swallow them. The one thing you need to remember about antacids is that they interfere with a lot of drugs, so it's best to give them alone. And if you have to give like an H2 blocker, because sometimes patients are on histamine receptor blockers, you'll want to wait about an hour to 2 hours before you give if they've had an antacid, along with if they're taking antibiotics or Carafate, like your PO antibiotics, because it can interfere with the absorption of the drugs. Okay, another group of category drugs ordered are histamine receptor blockers, and these drugs work by blocking the histamine, and it causes the parotid cells to decrease their production of hydrochloric acid, which decreases gastric acid. Some popular drugs are like ranitidine, also called Zantac, or famotidine, also known as Pepcid. Now these drugs are typically used short term, and a patient takes them as symptoms present, like PRN. And again, you don't give them with antacids. Wait about an hour or two before you give them, because it can interfere with how they work. Okay, other drugs, proton pump inhibitors, PPIs. Some popular drugs that are PPIs are like omeprazole, like Prilosec, or protanozole, like Protonix. And these decrease stomach acid and help the esophagus heal. Now, one thing about PPIs is that they will use them long-term, but long-term usage of PPIs increases a patient's risk of bone fractures. So watch out for that and assess your patient for that. Now, how PPIs work is that they attach to the proton pump of the parietal cells. So your hydrogen and your potassium, that's your proton pump. However, it blocks the release of hydrogen, so it can't mix with those chloride ions, which would make hydrochloric acid, HCl, so it's not formed, so it'll decrease the stomach acid. Another group of drugs used are called prokinetics, and these work by preventing delayed gastric emptying, by improving the lower esophageal pressure, and improves peristalsis. So they have like a cholinergic effect, because remember, our anticholinergics cause delayed gastric emptying. Some drugs that are considered prokinetics are bethanechol or metoclopramide, also called Reglan. Okay, so that wraps up our lecture on GERD. Thank you so much for watching. Don't forget to take the free quiz and to subscribe to our channel for more videos.